So good evening, all the aspirants present here. So our topic for today is maternal medicine, and the faculty that we have here is Dr. Varun Pushkarna sir. So you may.
Thank you, Sana. Thank you. Good evening, everyone. It's a very important topic and not very avidly covered in most of the textbooks, although it is important because you will get at least one or two questions in MRCP exams. So there are not much topics about maternal medicine, but avidly, effectively speaking, you will have maternal hypertension, you'll have maternal, diabetes and stuff like that. So I have selected very few topics which are of ultra most importance, and we will be discussing them, like embolism, pulmonary embolism in case of uh, pregnant patients. So let's see. We will discuss it via a question because you will get to know the format in which they are going to appear in front of you. So we have a 32-year-old G2P1 woman. So second gravida of 1 para at 30 weeks gestation. She has come to you with worsening shortness of breath over the past 2 weeks. She denies history of cough, fever, or chest pain. Her first pregnancy was uncomplicated. She has no history of heart disease, hypertension, or diabetes. So, what important history that these people have given us is one is that she's a 32-year-old lady who is pregnant at 30 weeks and she's having worsening of shortness of breath over the past 2 weeks. So, what is the average time when a pregnant female starts getting breathless? Yes.
After 7 months, sir.
So basically in third trimester. And why is it so?
So generally due to the distension of abdomen.
Okay. Anything else? Anything to do with the fluid overload and stuff? So these are very important topics and points. So basically, there are some physiological changes that are happening in a pregnant female that lead to dyspnea of pregnancy.
So your last point was not clear. Actually, sir, can you please repeat?
So basically, there are certain factors which are involved in the third trimester of pregnancy which lead to dyspnea of pregnancy. So that is a very common thing to observe. So it's a physiological dyspnea of pregnancy. It is a, so we define it as, so this is what we have here is, right? Dyspnea of pregnancy, DOP. Dyspnea of pregnancy. So dyspnea of pregnancy is usually physiological. So the reasons are, number one is mechanical, as you rightly pointed out, that the gravid uterus. So the gravid uterus is pushing the diaphragm upwards, leading to decrease in the FRC of the patient. So functional residual capacity decreases. Then the chest wall circumference also increases. Why does that increase? Any idea? Chest wall circumference increases. Any idea? So progesterone is such an important hormone that if that it is not there, labor may not progress. Why? Because progesterone relaxes all the joints, all the joints. So even the pubic symphysis relaxes, the sacral joints they relax, the sacroiliac joints they relax. Same way, these costochondral joints, the costovertebral joints, they also relax, leading to broadening of the chest wall cavity. Then, of course, dyspnea of pregnancy, out of these mechanical, then comes the hormonal dyspnea of pregnancy. So that is itself a progesterone effect. So progesterone leads to stimulation of a respiratory center in the medulla. So stimulates a respiratory center in medulla. So respiratory center. This increases the sensitivity to carbon dioxide. So that is why the patients are tachypneic even at normal carbon dioxide levels. This is called physiological hyperventilation. You will always see that a pregnant female in third trimester becomes very tachypneic. That is physiological hyperventilation. Third is, of course, increased oxygen demand because of a developing gravid uterus, developing fetus. The maternal oxygen consumption increases by anyone? So it's 15 to 20% oxygen consumption is increased. Then there is decreased reserve, that is FRC, as I've already told you. So what are the main four reasons for dyspnea of pregnancy? Mechanical, hormonal, metabolic, that is oxygen demand and carbon dioxide production. And then it is positional. What is positional? Orthopnea is there. Why orthopnea is there? Because of the gravid uterus pressing upon the venous return. So when the venous return is impinged, what goes down? What goes down? So the cardiac output goes down. Okay. Is that clear? Yes, doctors? Am I audible?
Yes, sir.
So basically we have four major physiological reasons for dyspnea of pregnancy. But what are the reasons for pathological dyspnea? So as a doctor, it is our job to differentiate between physiological and pathological. So they are mainly divided into pulmonary, that is lung and ventilation. Second is cardiac. Third is very important, hematologic. And fourth is metabolic. Fifth is miscellaneous. So in pulmonary causes, you can have pulmonary embolism. Why? Because the pregnancy is considered as a hypercoagulable
Hypercoagulable
state. So the patients are at a high risk of developing pulmonary embolism. Then because of the pressure on the lungs, there may be basal atelectasis, which may progress to a level where it becomes pathological. For example, a patient with pre-existing bronchial asthma. Then another is amniotic fluid embolism. So these are the things that we should never forget. Amniotic fluid embolism. Then of course comes cardiac. So one pathological is pulmonary that we just covered. Then comes the cardiac. So in the cardiac, what we have here is number one is peripartum cardiomyopathy. So that classically starts happening in the last month of pregnancy and occurs up to 6 months of postpartum period. So peripartum cardiomyopathy. Features are dyspnea, orthopnea, and all these things. Echo LV should be less than 45%. Then pre-existing rheumatic heart disease, for example, MS, MR, or any of these. Then cardiac is preeclampsia. Why preeclampsia? Because of the increased blood pressure, there is pulmonary edema. So that also leads to this thing. And then there are certain drugs known as tocolytics. Now these tocolytics are basically beta-2 agonists. So beta-2 agonists cause fluid retention and tachycardia. These are very important things that one must know when we are talking about pregnancy. That is why I started off with that topic, that is dyspnea of pregnancy. Then comes the hematological reasons. So cardiac we've done, it is cardiomyopathy, pre-existing rheumatic heart disease, preeclampsia, and certain drugs associated with cardiology. Then hematological. Hematological, one is severe anemia. Okay. So then is thyrotoxicosis. Many patients are thyrotoxic. So thyrotoxicosis, always rule out a patient of shortness of breath, pregnancy, third trimester, always rule out thyrotoxicosis. And miscellaneous, you will have something known as supine hypotension syndrome. What is supine hypotension syndrome? Again, that is pressure of gravid uterus on venous return leading to decrease in the cardiac output. So, am I clear with the classification of dyspnea of pregnancy?
Yes, sir.
Great. So let's now go back to our question. So this 30 weeks pregnant lady, she has come with shortness of breath, which is worsening over the past 2 weeks. So she denies any cough, fever, or chest pain. First pregnancy was uncomplicated. She has no history of heart disease, hypertension, or diabetes. So we are dealing with dyspnea of pregnancy. What are the blood pressures and all vitals? BP is 108 by 64. So hypertension, preeclampsia, they are all ruled out. Heart rate is 112. So she has tachycardia. That means either it is supine hypotension syndrome, but she has a progressive worsening history. It could be rheumatic heart disease. So patients many times they do not remember if they have rheumatic heart disease. They do not know if they have ever been diagnosed with it. Respiratory rate is 22. The saturation is 94% on room air. JVP is elevated. Bibasilar crackles are heard on lung auscultation. New S3 gallop is present. Bedside echocardiography is done, which shows LV ejection fraction of 30%. No valvular abnormalities, normal chambers dimensions in the right heart. So what is the diagnosis right now?
Peripartum cardiomyopathy, maybe.
Wonderful. So what are the features supporting your diagnosis?
So it's a late pregnancy, and patient is having features of heart failure.
Which are the features of heart failure?
So elevated JVP, basilar creps, and ejection fraction reduced to 30%.
So the first is heart rate of 112. So tachycardia. Why tachycardia occurs in heart failure?
Compensation.
So it is basically whenever the cardiac output is decreased, the patient, the baroreceptors, they increase epinephrine release. So that is sympathetic outflow. So sympathetic outflow is increased. This sympathetic outflow leads to increase in heart rate and also is basically aimed at increasing systemic vascular resistance also. But this patient has a poor ejection fraction that comes later. The new S3 gallop, you should always look at the physical findings that have been given. So S3 and S4, they are both of them, they are hallmarks of acute heart failure. This is when we want to go for an echo. So when the patient has tachycardia, tachypnea, poor oxygen saturation, elevated JVP, bilateral crackles, and on auscultation there is a S3 gallop. Yes, what I want to do is I want to do an echocardiography. Why? I want to see the LV ejection fraction. So that also comes to 30%. That confirms my findings of supposedly heart failure, probable heart failure. Now that LVEF is proven 30%, now it is heart failure only. So this becomes a diagnosis of, as you said, peripartum cardiomyopathy. So peripartum cardiomyopathy, correct. Preeclampsia with pulmonary edema with a blood pressure of 108 by 64. We cannot have a diagnosis of preeclampsia. Viral myocarditis, she has not been given, no history of fever has been given, or cough, cold. Amniotic fluid embolism can occur theoretically, but she has not gone into labor that she will push amniotic fluid into her circulation. Pulmonary thromboembolism, it has been shown in the echo that there are normal chamber dimensions for right heart. What happens to the right heart in pulmonary thromboembolism?
So we may find a clot in the atrium.
That is a very rare finding. What is the normal finding? The clot will be in atrium. That is a surrogate marker for clot in the pulmonary arteries. But that is not the finding we are looking for. If we find that, it is very good. But if we don't find that, that doesn't mean the patient does not have pulmonary embolism. So imagine the right ventricle was pumping the blood into pulmonary arteries and there is a thrombus here. So what will happen? The right ventricle will
Enlarge.
yes, it will dilate. And when it dilates, what happens is the blood flow goes back into the right atrium. What is it known as? Tricuspid regurgitation. So there is dilatation of the RV, right ventricle, and there is a tricuspid regurgitation. Both of them, which mean the patient has a pulmonary hypertension. And it is an isolated event. The left ventricle should be absolutely normal. If the LV is normal, we cannot call this patient as left ventricular dysfunction. It is right ventricular dysfunction in case of pulmonary thromboembolism, or some ladies have primary pulmonary hypertension. So you will still have right ventricular dilatation and presence of tricuspid regurgitation, leading to a diagnosis of pulmonary hypertension. So here we have a normal chamber dimension in the right heart. So pulmonary thromboembolism is out of question. It is very important to realize why it is the right answer and why the others are wrong answers. Okay. So correct answer is peripartum cardiomyopathy, which is also known as PPCM, which is a dilated cardiomyopathy occurring towards the end of pregnancy or within 5 months postpartum. It presents with symptoms of heart failure, that is dyspnea, orthopnea, elevated JVP, S3 gallop on auscultation, and reduced LV ejection fraction without any other identifiable cause. So the risk factors are multiparity, age more than 30, people with African descent, presence or history of preeclampsia, and multiple gestations. So higher the number of fetus, this is the problem that can happen. Distinguishing features are the patient will not have hypertension, will not have proteinuria, which rules out preeclampsia, no signs of embolism or infection. What is the treatment? Standard treatment of heart failure. What is the standard treatment of heart failure? What is
Diuretics.
What is GDMT? You are preparing for MRCP, you should know GDMT. What is GDMT?
So something like guideline based management, I think.
It is guideline directed medical therapy. So it is, so if we have this thing as heart failure, then the heart failure stands on 4 pillars of management of GDMT. That is, number 1 is ACE inhibitors or ARNI or ARBs. B is beta blocker. C is SGLT2 inhibitor. And D is mineralocorticoid diuretics, MRA. So this is goal directed. But the problem is in pregnancy, you cannot use ACE inhibitor, ARBs. Okay? You cannot use this. You can only start ACE inhibitors after the delivery. So avoid ACE inhibitors and ARB until after the delivery. So then what will you do? You will treat the patient with, nowadays there is a drug which is used to treat, what is the drug known as? So it is bromocriptine. Okay. Bromocriptine is used to treat peripartum cardiomyopathy. Essentially, we cannot use GDMT, which is these 4 drugs. All right. Okay. So that is a broader term for heart failure treatment. Let's move on to the next question. A 27-year-old G1P0 at
So
13
why
years,
we cannot use ARBs and ACE inhibitors in pregnancy?
because they are teratogenic.
Okay, so
As simple as that. That is one of the reasons why beta blockers also cannot be used, because they can produce bradycardia in fetus. And fetal bradycardia becomes one of the indications for emergency cesareans. So that is why we do not use. And the cardiac output of the fetus is very high. So the average heart rate of the fetus is 150, 160. If you are giving your patient beta blockers, the beta blockers will reach the placental circulation and reach the fetus, and they will cause bradycardia, lead to growth retardation. Okay. So again, beta blockers are also not recommended. So SGLT2, provided you can prove that the patient does not have, this is actually a class in altogether in itself, it is a different class. So the management of heart failure with medicines. So that is why you should understand that ABCD approach, that is the, and then you should be able to read the ECG. There should not be any, left bundle branch block. The QRS duration should be less than 160. There's a lot of things involved in that. But broadly speaking, the management of heart failure as such is very, very ultra important for the exam of MRCP, because around 40% of the European and uh, Great Britain people are suffering from heart failure because of obesity, diabetes, hypertension, coronary artery disease, kidney disease. So its management, there are proper nice guidelines for the management of heart failure in pregnancy also. So you should go through them. You will get a lot of insight. And in case you have some problems in understanding, come back to me. I will discuss the things with you. All right.
Okay, sir.
So another question, a 27-year-old first gravida, 34-week gestation comes to emergency department because of persistent headache and visual blurring for past 2 days. So what are the positive symptoms? Persistent headache and visual blurring for the past 2 days. She also reports mild upper abdominal discomfort. Her pregnancy has been uneventful so far. So she is 34 weeks and now she has headache. Plus she has blurring of vision. Any thoughts on this?
The features of preeclampsia.
Features of raised ICP.
Yes, sir. Yes, sir.
So when we are we don't jump to conclusions. We try to stay on the symptoms provided to us, and then we try to solve the equation by putting everything that has been given to us one by one. So right now what we have is headache and visual blurring, and this is a feature of intracranial hypertension. Okay. Now, this is a matter of investigation. What is causing this intracranial hypertension? All right. So this is how we'll progress and proceed to find what is happening. On examination, we found out that the blood pressure is 168 by 108. So headache and blurring of vision, that means intracranial hypertension. And what we see is BP is 168 by 108. All right, this could be preeclampsia because or gestational hypertension. So let's find out if there are other things present. Heart rate is 88. Respiratory rate is 18, so she doesn't look to be in distress. There is no vaginal bleeding. Reflexes are brisk and there is mild pedal edema present. So we have pedal edema. Although it is mild, again, this goes in the favor of preeclampsia. Urinalysis shows 3 plus proteinuria. I think it is the diagnosis is clinched by now. So it shows 3% proteinuria. So what we have is hypertension, pedal edema, and proteinuria. This triad is known as a triad of preeclampsia. Okay, along with headache and blurring of vision. So laboratory studies show platelet count of 85,000. So we have thrombocytopenia. And we have SGOT-PT elevated at 125 and 110. So LFT are deranged. What is HELP syndrome? Yes.
Hemolysis, elevated liver enzyme, and low platelet.
So is it hemolysis?
Hemodilution. elevated liver enzyme, and low platelet count.
So it is not hemodilution, it is hemolysis. I was thinking if somebody would say hypertension. So because that is the confusion mostly students have, that HELP syndrome is hypertension and elevated liver enzymes. So no, it is hemolysis, it is elevated liver enzymes, and it is low platelets. So H is hemolysis. So elevated liver enzymes and low platelets. So this is actually considered as a variant of severe preeclampsia. The creat is also slightly high. All right, there will be hypertension and proteinuria. So the creat is also high. What is the most appropriate next step in the management? Start labetalol and monitor the blood pressure until term. Give magnesium sulfate and plan for immediate delivery. Give steroids and delay this delivery for 48 hours. Start methyl dopa and reassess in 24 hours. Begin IV hydralazine and restrict fluid intake. Anyone? So we have a diagnosis of HELP, which is a severe form of preeclampsia. Now tell me what to do.
So
Plan
we can
I
for
plan
think
for
give magnesium sulfate and
magnesium
plan
plan
for
for
immediate
delivery.
So this is
magnesium
severe.
sulfate.
Yeah. So why not A?
Labetalol.
So the treatment for severe
Because there is
preeclampsia is termination of pregnancy.
Very good. Anyone else?
because there is pre-eclamptic features like blurring of vision, blood pressure is
Very
also high,
good.
and so we have to
the
see.
labetalol. So the labetalol would be a great choice if the patient was only having gestational hypertension. But here, it is not only gestational hypertension, it is a complication of gestational hypertension. The patient has intracranial hypertension, the patient has hemolysis, the patient has liver edema, liver enzymes, patient has low platelets, pedal edema, the patient has deranged creat also. So the next thing is going to happen is the patient is going to throw seizures. The patient is going to have fits.
Eclampsia.
Yes, and then we will be in a soup. So the primary thing is that as the patient already has blurring of vision, immediately give her magnesium and terminate the pregnancy as soon as possible, because otherwise the lady will have a poor outcome herself. She might have an intracranial hemorrhage also. All right. So correct answer is give magnesium sulfate and plan for immediately delivery. This patient has severe preeclampsia and has features of HELP syndrome, hemolysis, elevated liver enzymes, and poor platelet count. Blood pressure more than 160 by 110, proteinuria, elevated enzymes, thrombocytopenia, neurological symptoms, they all confirm severe disease. What is the definitive treatment? Unless you have a compelling indication, you should lead to delivery, regardless of gestational age. No steroid, no betamethasone, no dexamethasone. If it is after 34 weeks, don't wait for anything. Just perform delivery. Magnesium sulfate is a seizure prophylaxis. No drug has been proven to have a seizure prophylaxis effect. So only magnesium is proven. Antihypertensives, they are added for only BP control, but they do not replace the decision for delivery in case of a preeclamptic patient. All right. So we did cover two topics. One is breathlessness in pregnancy. Second was hypertension in pregnancy with severe features. Now we have another major stalwart, that is diabetes in pregnancy. So we have a 30-year-old lady, G2P1, so second gravida, 36 weeks, comes for routine antenatal follow-up. She has gestational diabetes mellitus, diagnosed at 20 weeks, 28 weeks, initially managed with dietary restriction. Her home glucose log shows the following feature despite good compliance. Fasting is 110, 2-hour postprandial 160. Fetal ultrasound shows an estimated fetal weight of more than 90th percent. Next best step in the management. Continue dietary therapy and reassess in 2 weeks, or initiate insulin therapy, or start metformin, or plan for induction at labor 37 weeks, or perform non-stress testing twice weekly. So what do we have here is, we have a gestational diabetes which is not getting controlled by dietary modifications, and we have a large for size baby. Okay. So we have a macrosomia. What do we have? Macrosomia. So what will we do?
Insulin. We should
What
start
are
insulin.
the okay, very good. So we will start insulin. Me to the point of knowledge that what are the goals of sugar control in diabetic females, in diabetic pregnant females. So what are the goals? Anyone?
Postprandial after 2 hours, it should be below 140, and the fasting should be
What are fasting
100.
glucose level female? So fasting should be less than 95, and 2-hour patient is not in control. So 1 hour postprandial or 2-hour postprandial. So this is 2-hour postprandial, sorry. So 2-hour postprandial should be less than 120. 140 is 1 hour postprandial. 2 hour is 120. Okay. So the best next step is putting the patient on insulin. So start insulin in this patient. Why? This is a gestational diabetes which is not controlled by diet and exercise. This requires insulin, which is the standard of care and safest modality during pregnancy. Oral agents like metformin or glyburide may be considered in some cases, but insulin remains the first line for persistently elevated fasting, that is more than 95, or postprandial more than 120. Macrosomia, that is size more than 90 percentile, increases the risk of shoulder dystocia or birth injury, emphasizing need for tighter glucose control. Goals in GDM are fasting less than 95, 1 hour postprandial less than 140, or 2 hour postprandial less than 120.
120.
So fetal surveillance, that is NST or BPP, usually started at 32 to 34 weeks after metabolic control is achieved. So not before that. All right. Gestational diabetes, very important guideline. So what is the fasting blood glucose level in gestational diabetes?
94.
Less than 95. And 1 hour postprandial less than 140.
140.
And 2 hours postprandial
120.
Less than 120.
What is the drug of choice in uncontrolled diabetes, gestational diabetes?
Insulin.
Insulin. You can use these agents, but rarely. The first line is insulin, and it is best given as basal bolus, that is 2 injections you can give. Another thing is, what is macrosomia? Macrosomia is when the fetus is more than 90th percentile for their body weight. Why it is important? Because it causes shoulder
Shoulder
dystocia
dystocia.
and difficult delivery also.
Delivery.
Okay. All right. Next question, again very important. A 29-year-old, second gravida, first para, 28 weeks gestation, presents with acute onset shortness of breath and right-sided pleuritic chest pain for 4 hours. So what are the positive findings? There is shortness of breath, plus there is pleuritic chest pain, which was not there earlier. No cough, no fever, no cough pain. Previous pregnancy uncomplicated. Temperature is slightly high, 98.6. BP is 110/70. There is tachycardia 118. There is tachypnea 24. There is hypoxia, that is saturation 90% on room air. On cardiac examination, there is tachycardia but no murmur. Chest is clear to auscultation. There is some tenderness in the leg on the right side, but no swelling. ECG shows sinus tachycardia. Chest X-ray is normal. What is the next best step? What is the diagnosis likely here? So shortness of breath or dyspnea of pregnancy with chest pain. What do you think of? Think of
Pulmonary
Pulmonary
embolism.
embolism.
pulmonary embolism. So what is the next best step? She is at 28 weeks pregnancy. CT pulmonary angio,
No, sir.
D-dimer,
No.
ventilation perfusion scanning,
Scan.
Yes, sir.
Ventil.
or
VQ
lower
scan.
extremity Doppler,
We
or
should do
scan.
first a
echocardiography.
Doppler.
So the
We can
most,
do
yes,
with
the least
ventilation.
the least risky and least invasive test is lower
Doppler.
extremity Doppler
Ultrasound.
ultrasonography. So once you see the duplex and you see that there is a clot there, a remnant clot in the, because there is tenderness in the right calf. So we have a probable diagnosis of pulmonary embolism. So the next best answer is lower extremity Doppler, because even if the clot has dislodged and gone completely, still the patient will have some degree of venous derangement in the veins. In pregnancy, venous thromboembolism is the leading cause of maternal morbidity and mortality. Cause may be any. Pregnancy itself is a prothrombotic state. Although these patients may also have a history of SLE, history of trauma, history of EPLA, lupus anticoagulant, homocystinemia, all these things, they can be there, but pregnancy itself remains the biggest cause of
Pulmonary thromboembolism.
DVT, because pulmonary embolism occurs after DVT.
After the DVT.
So DVT ka one of the most important reason is pregnancy. Radiation exposure is to be minimized in pregnancy. Hence, we take a different route in pregnant females. Initial test is compression ultrasonography of the lower extremities. If you find the DVT, anticoagulation is started immediately without further imaging. If the patient has a massive pulmonary embolism, you can even thrombolize. Thrombolysis in pregnancy is a relative contraindication. It's not an absolute contraindication. If DVT is not found, then you would like to go for imaging of the chest. If leg Doppler is negative, but you still suspect that the patient may have DVT and embolism, so ventilation perfusion scanning is done over CT angiography if chest X-ray is normal to reduce the fetal radiation exposure. CTPA is done only if the chest X-ray is normal and we could not find properly in ventilation perfusion scan. D-dimer, D-dimer वैसे भी pregnancy में positive आ जाता है. So there is no role of D-dimer in gestational thromboembolism. So D-dimer is not reliable in case of pregnancy. So what are the key points? Number one, that you do a peripheral venous Doppler to confirm a diagnosis of DVT. If it is there, you start the anticoagulant, and low molecular weight heparin is the first line anticoagulant and is safe in all trimesters of pregnancy. So why not use it? Warfarin, because it can cause coumarin teratogenicity, warfarin syndrome, and DOAX, they are all contraindicated in pregnancy. Interesting thing is that anticoagulation should continue for at least 3 months and until 6 weeks postpartum. So you must consider anticoagulating the patient even after the pregnancy has been finished. Is that okay?
Yes, sir.
Now is a very interesting question, very close to my heart. I have seen at least 7 to 10 patients in last 1 year for this patient. A 29-year-old woman, second gravida, first para, at 34-week gestation is found to have a platelet count of 92,000. During routine prenatal screening, she is asymptomatic. No petechiae, no purpura, no mucosal bleeding. Blood pressure is 110/70 and there is no proteinuria. Review of her previous record show a platelet count of 1,05,000 near term, which then normalized to 1,80,000 few weeks after delivery. Peripheral smear shows normal platelet morphology and no schistocytes. So what is the diagnosis? ITP, gestational thrombocytopenia, HELP syndrome, TTP or preeclampsia.
Gestational thrombocytopenia. Okay.
Correct. So this is gestational thrombocytopenia. We don't usually read about it, but then this is true. These patients will have only thrombocytopenia only during the
During the
pregnancy.
gestational time.
So when the pregnancy is finished, the platelet count will return back to their normal.
Normal.
So this is gestational thrombocytopenia. It is the feature of gestational thrombocytopenia. This is comparison between GT and ITP. So the onset is mid to late second or third trimester of pregnancy, but in ITP it can present at any stage. Platelet counts usually do not go below 70,000, and in case in ITP they can go below 50,000 also. Gestational thrombocytopenia patient is asymptomatic and may have a prior history also, whereas in ITP they may have purpural rash,
Throat.
petechiae, mucosal bleeding, all of these things they may happen. In fetal involvement, the gestational thrombocytopenia, the fetus is not involved, their platelet counts will be normal. But in case of ITP, the antibodies they can migrate transplacentally, hence they can lead to thrombocytopenia of the fetus also. So this is very important to differentiate between gestational thrombocytopenia and immune thrombocytopenia or ITP. So in history, there is normal platelets before pregnancy, and also patient gives history of spontaneous normalization of platelets after the delivery. In ITP, patient may have a long-standing history of thrombocytopenia before or without pregnancy. Many times they are diagnosed patients of ITP. Management is, in case of gestational thrombocytopenia, it is only observation, whereas in ITP, the management is steroids or even IVIG can be given if the platelet count is less than 30,000 or if the patient is bleeding. You can just give steroids. So key points to remember is that gestational thrombocytopenia is benign, and the most common cause of thrombocytopenia in pregnancy, around 75% of the cases with low platelet count during pregnancy are benign gestational thrombocytopenia. No treatment is required. Platelets will usually normalize. So all you need to do is good counseling. ITP is to be suspected if platelet count is less than 70,000 and with bleeding manifestation and present in first trimester, because gestational thrombocytopenia usually manifests in second or third trimester. History of thrombocytopenia before pregnancy will be there in ITP, and you might have features of bleeding, mucosal bleeding, or neonatal thrombocytopenia. So that is all for today. I couldn't find more interesting topics for this problem, that is gestational medicine, and I think covers everything that gestational medicine stands for. Any questions? I'll take it if there are no more questions.
Sir,
Then-
if the patient is on magnesium sulfate and in spite of that she's seizing, can we add Levipil in this case? Because phenytoin we cannot give in
See,
pregnant patients and
see, it
seizures are
is-
still on before
it is-
taking to OT.
Yeah, you're right. So I think in that situation, midazolam is the drug of choice.
Midazolam. Okay.
Yeah.
Okay, sir.
So benzodiazepines will
Hmm.
be, the backbone that we will see. If the seizures in preeclampsia are there despite magnesium, then
Hmm.
we should have a what is known as a seizure backup with us. So we will need, why? Because what we have here is either you can increase the dose of magnesium, which is very important. Sometimes what happens is people give magnesium, but the dose is not correct. So if ideal situation would be, I would still give another dose of magnesium. And if not yet, then I would like to go for the usual course of epilepsy management. Like start with benzodiazepine.
Okay, sir. Thank you,
Yeah.
sir.
So that is all we can do. As far as your other drugs are concerned, like Eptoin, Levipil, see, these drugs are very, very notorious. They are not the first line drugs, and they may cause neonatal neurological depression also. And as far as these benzodiazepines are concerned, even if they cause neonatal depression, you can always use flumazenil. So it is a reversible kind of a depression if at all it happens. All right.
Thank you so much, sir.
Okay.
you very
All
much,
right.
sir.
Thank you very much, students. Bye bye.
Thank you, sir.